Hello everyone. In this video, we'll discuss urine analysis, ki how to see urine report and identify a clinical disorder. We will discuss a parameter to assess, proper technique for urine collection, and interpretation with some real case scenarios. How to collect the urine. So you should always tell the patient to collect a midstream urine sample. Examination should be ideally done within 2 hours of the collection. Sample should be refrigerated at 4 degree if there is a delay in the urine analysis for up to 24 hours. It can be kept in refrigeration. In a clinic, when the patient come in late evening, so the lab might be closed. So in that case, this will be a very useful technique to preserve the urine sample. Any sample which is older than 24 hours should not be used for urine analysis. What are the parameters to be assessed? So in the assessment, we check for physical parameters, chemical parameters, and microscopic examination of the urine. Physical examination. Physical examination, as you can see, we look for the color of the urine, appearance like turbidity or clear, urine pH we will assess, and the specific gravity. So out of this, the important parameter clinically are the color of the urine and the specific gravity of the urine, and in some cases pH will be useful. So what are the normal values? So you can see the normal values, color is pale yellow, appearance is clear, there is no turbidity, pH range from 5 to 8. Some labs take 4.5 and 7.5 as the limits, and specific gravity is 1.005 to 1.030 with again some variation in different labs. Now the chemical examination. So the chemical examination is usually done with the help of a urine dipstick. So most of the labs, they check for the chemical examination with the dipstick, so in which the proteins are checked, normal is negative, urine sugars are checked, negative, ketones negative, nitrite, blood, they are all negative. Now the urobilinogen. Urobilinogen is a normal component of the urine. Bilirubin goes into the intestine and converted into urobilinogen, which is then excreted in the urine. So if the urobilinogen is absent, that means there is a obstructive jaundice. While urine bilirubin is negative normally, and if it is positive, that means ki in the blood bilirubin levels are elevated, which are conjugated high bilirubin levels. So these are the chemical examination. While in the microscopic examination, we check for the red blood cells, erythrocytes. Normal value is less than 2 RBCs per high power field. Pus cells are WBCs. So it is less than 5 WBCs per high power field. Epithelial cells can be squamous epithelial cells, transitional cells. So the value is less than 5. Cast usually not seen. Crystals, they are not seen. So one by one, we'll discuss the abnormality of urine analysis. So in the abnormality, physical examination, color. So the normal color is pale yellow, but if the color become different, so we can identify what exactly will be the cause. Same for the appearance, pH, and specific gravity. So starting with the color. If the color is brown, so it could be due to myoglobin, and myoglobin is due to rhabdomyolysis. It can be due to the intake of metronidazole. So suppose a patient taking metronidazole and give the urine sample, it can be a brown in color. So ask the patient history of metronidazole use. Similarly, for the nitrofurantoin is a medicine which is given in urinary tract infections. So after intake of nitrofurantoin, there can be a change in the urine color. So you have to tell the patient that grossly the color might change. So patient should not worry about the change in the color after nitrofurantoin use. Green or blue color, it is due to UTI due to Pseudomonas infection or intake of amitriptyline. Orange color is due to rifampicin, that is ATT. Red color is due to hematuria, or it can be hemoglobinuria or intake of the beetroot. So we will identify how to differentiate whether that is a true hematuria or it is due to hemoglobinuria or due to beetroot ingestion. There can be a red color urine. Dark yellow is concentrated urine or can be because of high carrot intake and jaundice. Now the appearance. Appearance can be a cloudy appearance, and cloudy appearance is due to high phosphate in the urine, phosphate urea. It can be pyuria, lots of WBCs in the urine. Chyluria, that is chyle formation, more excess of chyle formation, lipid urea or high uric acid. Now the pH. So pH will be important for stones and urine tract infections. So if the stone is due to calcium and staghorn stones, the pH will be towards the alkaline side. While if uric acid stones are present, then the pH will be on acidic side. So urine tract infection, if pH is towards the alkaline side, so it is a urea splitting protease which will be present, or it can be due to pseudomonas. While the most common cause of the UTI, that is the E. coli, it produces acidic reaction, acidic pH correlated with the E. coli or Klebsiella infection. While if the urine sample is there for a long time, old urine sample, that is the most common cause of a alkaline pH. So whenever you see alkaline pH like it is going towards 8, so suspect that it can be a old urine specimen. Specific gravity. Specific gravity means how heavy is the urine in relation to the water, and it is due to the presence of glucose or urea or less water in the urine. So it depends on the hydration status. So hydration status and concentration ability of the kidneys, they can change the specific gravity. So how it is changed? How high values like 1.030 towards that side. So it can be because of the dehydration. Because of the dehydration, water is less in the urine, urea. It can be SIADH. SIADH means ki excess of ADH hormone that absorb more water from the kidney tubules, so the urine will be more concentrated. Low values, that is seen in diabetes insipidus. ADH is not working or ADH is deficient, so more water will be there in the urine. While it can be because of excess fluid intake. So whenever you see a physical appearance of the physical examination of the urine is given as specific gravity, focus on the specific gravity, and then you can retrogradely ask the history from the patient. False elevation can be seen in excess of proteinuria, or it can be a falsely low in alkaline urine. Now the chemical examination. Chemical examination is the dipstick method. So in the dipstick method, we check for the blood, but blood detect the peroxidase activity of the erythrocytes, but it can be a false positive because this reaction can also be catabolized by myoglobin and hemoglobin in the urine. So they can cause a false positive blood reaction. So how will you differentiate? Just check the microscopy RBCs are present. If RBCs are present along with the blood positive in dipstick in chemical examination, that is a true hematuria. But if blood is positive but RBCs are absent, then it could be myoglobinuria or hemoglobin urea. So when urine color is red, so we centrifuge the specimen, and if there is a red urinary sediments, this is most likely a case of hematuria. While if there is a red supernatant and that is heme positive, it is hemoglobinuria or myoglobinuria. And if there is a red supernatant, that is a upper layer of the centrifuged urine specimen, that is red in color, but that is heme negative. So it can be because of the beetroot ingestion, and there can be other drugs like B12 or phenazopyridine. Phenazopyridine is a drug which is given for urinary tract infections. Proteinuria. Proteinuria detects the albumin, not the other globulins and benzose proteins. There can be the causes, two causes. One is a transient proteinuria. So whenever you see proteinuria positive, you always think of it can be a transient proteinuria or it can be the permanent proteinuria. So transient proteinuria can be because of the CHF. It can be because of dehydration, exercise. So when patient goes in the morning for morning walk, brisk walk, and then give the urine sample, it can have a false positive, or we can say not false positive, proteinuria positive can be there without any kidney disease. Fever can cause proteinuria. Orthostatic proteinuria means someone is standing for a long time, there can be a proteinuria due to increased glomerular filtration pressure. Seizures activity can also elevate the proteinuria. So these are the causes of transient. So you have to repeat the sample again, and if that sample is negative, it means it is a transient proteinuria. Persistent proteinuria are usually due to glomerular cause like glomerulonephritis or multiple myeloma. Now, false positive proteinuria can be seen in concentrated urine or alkaline urine, or because of the ingestion of that drug which we usually give for the UTIs. False negative can be acid urine or a diluted urine, and primary protein, when it is not albumin, then it can be falsely negative. Also, in some cases of microalbuminuria, it can be negative also. Now, glucoseuria, diabetes mellitus, SGLT inhibitor. So when you see a glucose positive reaction, so do not get scared. It can be the effect of SGLT inhibitor that patient is taking for diabetes. Diabetes is controlled, but there is a glucoseuria, could be drug effect. Fanconi syndrome, ketonuria. So ketonuria is seen in uncontrolled diabetes. It is more likely present in type 1 diabetes, but it can be seen in type 2 also when it is very high sugars. It can be due to SGLT inhibitor. This is very important. Whenever a patient of ketonuria come, also ask the history of SGLT inhibitor in type 2 diabetes. It causes euglycemic ketonuria. Pregnancy or starvation, like carbohydrate free diet, if patient is taking, then ketones can be positive. Nitrate. Now this is very important for urine tract infections. So nitrates, some bacteria reduce the urinary nitrates to nitrites. So it is a specific test for UTI but not sensitive, and positive in the nitrate reductase positive bacteria. What are those bacteria? Those bacteria are E. coli, protease and Klebsiella. So this is important, like a patient might have taken antibiotic and after antibiotic urine culture is negative, but nitrite can be positive. Leukocyte esterase, again a marker of urine infections. So it is produced by the neutrophils. It indicate pyuria, lots of WBCs, means it is a leukocyte esterase positive. So it can be positive in the UTI for those bacteria which are not grown in a standard culture, atypical bacteria like chlamydia, mycobacterium tuberculosis or urea plasma urealyticum. In this, the standard cultures are negative, but leukocyte esterase will be positive. Bilirubin and urobilinogen. Normally, if urine bilirubin is positive, that indicate a conjugated high bilirubinemia, means it is due to hepatitis or obstructive jaundice. While urine urobilinogen is, if it is negative, then it is abnormal. It is seen in antibiotic use because antibiotic destroy the gut bacteria which help in the formation of urobilinogen, or it could be due to bile obstruction because from the liver bilirubin is not excreted through bile into the GIT, so it will not make urobilinogen. So these are abnormal findings in the urine, Microscopic examination. So microscopic examination will look for the cells like WBCs, RBCs. We look for the cast, crystals and microorganisms. So cells, red blood cells will be positive, normal are less than 2 per high per field. Positive RBCs are present in urine infections. It can be positive in cancers or stones, or it can be due to inflammation like glomerulonephritis. WBCs normal are less than 5 and it is positive in urine infections. Eosinophils, they are normally absent. If they are present, that is allergic interstitial nephritis due to some drug intake. Epithelial cells. So epithelial cells can be squamous, transitional or renal tubular cells. Normally maximum limit is less than 15. I will take less than 15 as the normal limit. Some lab says less than 5 also, but I make the cutoff as 15. Squamous cell, they are most common and they represent the contamination of the urine sample. Transitional cell, they are normal or can be seen in UTIs. Renal tubular cells present, that is renal tubular necrosis. Now the cast. So the cast are the coagulum of TAM-Horsfall proteins which are normal proteins and the trapped content of the tubule lumen. So if anything is more in the tubular lumen, that make the cast, that can make the cast. So the cast can be hyaline cast, that is a benign cast seen in dehydration. So TAM-Horsfall protein, they accumulate. RBC cast is seen in glomerulonephritis because lots of RBCs are coming from the glomeruli into the tubules. WBCs in pyelonephritis, granular cast in necrotic cells like ATNs, acute tubular necrosis. Waxy cast is seen in advanced renal disease like in CRF. Fatty cast is seen in nephrotic syndrome because of lipiduria. Broadcast is seen in end stage renal disease because the lumen increase in size and there is a accumulation of TAM protein. Now the crystals. Crystals are on the basis of the shape, and very few labs give you the crystal findings. So that needs lots of experience in examining these crystals. Envelope shaped is calcium crystals. Uric acid are diamond shaped or barrel shaped. Triple phosphates are coffin lid. Cystine crystals are hexagonal shape. So these are the different types of the crystals. Like you can see, this is envelope shaped crystals. This is coffin lid crystals which are present, and this is diamond shaped crystals, and this is hexagonal crystals. Hexagonal. So these are the types of the different types of the crystals. Now microorganisms can be bacteria or yeast, which can be positive. Now a very important point is whenever urine is positive for nitrites, leukocyte esterase and bacteria, it is highly suggestive of urine tract infections. While if the squamous epithelial cells are present more than 15, so it means it can be a contaminated sample. So nitrite are positive, leukocyte are positive, but epithelial cells are more than 15. So always ask the patient to repeat a sample because there is a contaminated specimen. Now comes to the real case discussion. So these are the actual reports of the patient, and the normal values they differ lab to lab. They can differ from lab to lab. So real case scenario: 50-year-old female coming for a routine health checkup. Now let's see the urine analysis. So in the color pale yellow color in the physical examination, pH you can see is 5.5, slightly towards acidic side. Now look at the specific gravity. Specific gravity is low, and rest of the parameters, protein, glucose, everything is normal, and microscopy is also normal. So we ask the history from the patient, and the specific gravity is low. The specific gravity is low due to diabetes insipidus, lots of water in the urine, or it can be because of excess water intake. So this female history revealed that there was lots of water intake. So that makes the specific gravity less than 1.005. Now 66-year female with type 2 diabetes. So look here the reactions. pH is normal, specific gravity is almost in the middle, 1.0115, but you can see here the glucose is 3 plus, that is detected on the microscopy. So when the glucose is positive and rest of the findings are negative, so we will think of two possibilities. Why in a diabetes patient glucose is positive in the urine? There are two possibilities. Number one possibility is high blood sugar levels or uncontrolled sugars, or it can be because of the SGLT inhibitor use. So when we ask the patient history, she was not taking SGLT inhibitor and HbA1c was high, 7.9 you can see. So from that we can say that glucose positive is due to high blood glucose, uncontrolled sugars. Young female comes for a routine health checkup, and these are the findings in which the leukocyte esterase is positive. So we will think of urine tract infections, and when we look at the pus cells were 8 to 10 per high per field. But look at the epithelial cells. Epithelial cells are 10 to 20. So that means this is a contaminated sample, most likely contaminated sample. So we have to repeat the sample again, and when we did the repeat, it came out to be normal. So always look at the whenever you are finding leukocyte esterase and pus cells, instead of going for a culture or instead of advising the antibiotics, just look at the epithelial cells. If they are high, could be a contaminated sample, and patient was asymptomatic. A 60-year-old female, type 2 diabetes, increased frequency of the urine. Patient is taking ciprofloxacin already for urine infections. HbA1c is 7.1. Now look here, pH is 5.5. So pH is on a acidic side. Grossly it was turbid, could be because of the high pus cells. Now the leukocyte esterase is 1 plus, and pus cells are 15 to 20. So that means it is most likely the urine infection which is leading to these findings. Squamous epithelial cells are 1 to 2, so this is not a contaminated sample. Non-squamous epithelial cells are also nil. So most likely this is urine infections, and urine infection which leads to acidic pH, we have done in the earlier section. E. coli and Klebsiella causes acidic pH. So we can correlate the findings. But patient is already taking ciprofloxacin, so most likely when you get the culture done, it will be negative. Most likely that is one of the common cause of a negative culture with pus cells. So yes, there was in the culture no growth was seen because patient was already taking ciprofloxacin. Patient already given the sample for the urine culture before consulting the doctor and started the antibiotic from the chemist. Now 62-year-old female, type 2 diabetes, HbA1c is 7, and patient is on SGLT inhibitor, dapagliflozin, glimepiride and metformin. Oral intake is very poor in this patient. So let's see what are the findings. So in this finding, if you can see, urine proteins are 1 plus, that is not good for diabetes patient, can indicate a nephropathy. Sugars are 4 plus. Sugar 4 plus can be explained by high blood glucose levels, or it can be use of SGLT inhibitors in a diabetes patient. Now look here, ketones are trace, and when we check for the infection, so leukocyte esterase negative, nitrate negative, and the leukocyte are normal. So that means ki there is no UTI from these findings. So what are the causes of this? Proteinuria can be due to nephropathy, maybe a diabetes nephropathy. This 4 plus can be because of SGLT inhibitor or high blood sugar level. What about the ketones? So for that, if we look at the HbA1c, HbA1c is not that high, it is controlled. So it means it is dapagliflozin which is causing the glucose levels. So SGLT inhibitor can lead to glucose as well as it can lead to ketonuria, we have discussed earlier. So SGLT can cause both the 4 plus proteins and the ketonuria. In this patient we have to stop the SGLT inhibitor, and nephropathy was old nephropathy of the patient, therefore the protein were 1 plus in this patient. Type 2 diabetes, for a routine checkup coming to us, the glucose value is present and the rest of the examination is okay. Now look at the specific gravity. When you see a specific gravity of 1010, this is a fixed specific gravity. Fixed specific gravity, that means ki maybe the tubular dysfunction is there, medullary tubules are damaged, they are not working. It is the specific gravity of the glomerular filtrate. When the glomerular filtrate come in the tubules absorb the water, but if they are not working, so whatever is the specific gravity of the glomeruli, that will be the specific gravity of the urine. So this is a fixed specific gravity. So always do kidney function test, assess the kidney parameter in these patients. This is a very, very important advice. We ignore this specific gravity in diabetes. Look at the specific gravity in these patients. So when the HbA1c was done in the patient, so HbA1c was 6.8. so most likely this patient will be taking SGLT inhibitor. So this effect is due to SGLT inhibitor in our patient. 6.8. Now, a type 2 diabetes routine checkup, vildagliptin, metformin, dapagliflozin, patient is taking, 77-year-old female. So obviously glucose is present and leukocytes are present in this patient. And when we did the pus cells were high and epithelial cells were 10 or less than 10. So that means it is not a contaminated sample. This is most likely the effect of high blood glucose, or it is the effect of SGLT inhibitors, and this is due to UTI. So we have to ask the patient for a urine culture, and yes, when the urine culture came, E. coli was present in our patient. Now recall back in E. coli, what was the urine pH? So in the E. coli, urine pH should be on a lower side. So the urine pH is here it is 5. So it is acidic urine pH. Acidic urine pH. 40-year-old female for a routine checkup, and the blood was positive in our patient, and rest of the findings were okay, so there was no issue. So whenever a patient of this age group come to you before the menopause, always ask the history of menstrual bleeding. So this could be a menstrual bleeding, blood can be positive, first possibility can be there. And the RBCs just were on the borderline, like 3 to 5 were the RBCs. Normal RBCs were less than 2 or less than 3. So it could be a effect of a menstrual cycle. Could be a possibility. So we ask the patient history, and then we'll do the repeat in between the menstrual cycles. Now patient has HbA1c of 9, uncontrolled sugars, so obviously glucose is positive here, and increased urine frequency is present. So proteinuria is there. So whenever there is a proteinuria, so it could be because of UTIs. So whenever in a diabetes, UTI can cause proteinuria. It can be because of the nephropathy. So if the urine infection is treated, so do not just observe the patient, ask the patient for a urine assessment, urine albumin creatinine ratio later on when the UTI settle. So in this patient, once a UTI is okay, then we will ask the patient for a urine albumin creatinine ratio. So for assessment of the proteinuria, whether that was due to the fever, whether that was due to infection, or whether it is due to diabetes nephropathy. 35-year-old recently diagnosed with diabetes, and these are the parameters that there is a glucose in the urine. In this patient, when we did the HbA1c was 12.9. So this glucose is due to high blood sugar levels. So we control the sugar levels, and this will subside. Asymptomatic 25-year-old female come for a preventive health checkup, and in this preventive health checkup, when you look at the pus cells, so pus cells were positive, but epithelial cells were 20 to 30. Now your answer is and leukocyte esterase is positive. So whether it is UTI or contaminated sample, UTI or contaminated sample, especially in females. So answer is this is a contaminated sample because the epithelial cells are positive. So always recheck the urine routine, and if patient is asymptomatic, then unlikely it will be urine infections, but some UTI can be asymptomatic, especially in diabetes or in elderly. So we should be aware about this important diagnostic possibility. Now this is the important clinical scenario. 30-year-old female present with the weakness and low backache. So when we did the analysis, so the analysis came out to be proteinuria 2 plus is present. RBCs are in large number, WBCs are positive, RBCs fulfilled. So first we think of whether it is due to the menstrual cycle. Patient is 30-year-old. No. Patient was not having a menstrual cycle. Patient does not have any urine frequency. So what we checked in this patient, whenever a proteinuria come and patient comes with a weakness, so kidney function test were done. So kidney function test shows creatinine of 1.27. According to the lab, it was on a higher side. Albumin was low. So that means it is some sort of a chronic disease. Maybe she is losing proteinuria through the urine. So albumin was low. Always check when patient is not diabetic, when patient does not have any UTI symptoms, but proteinuria is present. Do not ignore that proteinuria. First ask the history of exercise induced proteinuria, fever was there or not. Everything was negative, but these were the reports. Always get the kidney function test. But unfortunately, this patient didn't come for a follow-up, and we also did the ultrasound. Ultrasound was okay, kidneys were okay in that particular ultrasound, and we asked the patient for a follow-up after a week for urine repeat test and KFT repeat test, but she didn't come. When she came, it was too late. She came to us after 6 months, and after the 6 months, the urine was 2 plus proteinuria. There were RBCs present, and blood present in the chemical examination. There were RBC in the microscopy examination, and when we did the KFT increased to creatinine of 2.24. Albumin further reduced. So she was having some sort of nephritis, could be a lupus nephritis, could be idiopathic nephritis, so some sort of nephritis was there. Now your answers for practice, yes, be ready. This is the finding. Urine proteins are trace and pus cells are 2 plus. Patient is young female. So my question to you is, if the urine protein is trace in presence of UTI, so what will you do next? Will you go for a urine culture in this patient, or you will go for a ultrasound of the patient? So this is the clinical case scenario number 1. Case 1. Case 1. Young female comes to you with frequency of the urine proteins are trace and pus cells are positive. Will you go for urine culture, or will you go for a ultrasound? Now second one. Patient has proteins 2 plus, glucose 2 plus, and epithelial cells are 10 to 12, that is okay, and creatinine is high, 6.7. Potassium is also high. Urine microalbumin report is also elevated. HbA1c is 10.3. So in this case number 2, what is your diagnosis? Diagnosis is why this proteinuria is occurring. Patient is having a type 2 diabetes. The cause of the proteinuria you have to tell in the comment section. So this is the clinical case number 2. So share your experience ki how you are analyzing the urine report, and if any atypical finding you have got in your patient, or any interesting diagnostic case, diagnostic disease was there, so you can share in the comment section. Thank you.